Also, welcome. I want to welcome, as always, my vice chair, Evelyn Terrell, that she's here with us as well. Today's presentation, first of all, we're going to start with the presentation. I'm going to begin with just very highlight stats on what is happening worldwide and in our society with opioid addiction. And then I'm going to introduce our esteemed presenter today and colleague, Dr. Josh Lenchens. We will then subsequently, after his presentation, we will open up for Q&A. So please feel free, raise your hands. I will be calling on you, and feel free to go ahead and ask your questions. I'm sure you have lots and lots of questions for Dr. Lenchens this morning. So worldwide, approximately 5.8% of the global population ages 15 through to 64 years of age have used drugs at least once in 2021. And among them, 60 million people have used opioids. About 39.5 million people live with a drug use disorder in 2021. Worldwide, about 600,000 deaths were attributed to drug use in 2019. Mind you, that was before the pandemic of COVID-19. Close to 80% of these deaths are related to opioids, and about 25% of those deaths were caused by opioid. Also, the opioid epidemic cost the United States a record of nearly $1.5 trillion in 2020. And this was a double-digit increase, about 37% from 2017. We know that causes are multifactorial, but very importantly is the easy access to drugs, substance abuse, and of course, mental health disorders, just to name a few. Today, we're honored to have our guest speaker, an expert in this important healthcare and societal challenge, my good friend and colleague, Dr. Josh Lenchens. Just a little bit on him, because I cannot do any justice to his incredible CV. He holds a pharmacy degree from the University of Florida and graduated from Nova Southeastern University College of Osteopathic Medicine. He completed his internal medicine at Jackson Memorial Hospital. That's where we met many, many years ago. Subsequently, he worked as a hospitalist for the University of Miami Miller School of Medicine, and he holds the rank of Associate Professor of Medicine, Anesthesiology, and Radiology. He also served as the Associate Program for the Internal Medicine Program for 9 years. And most recently, he was a Senior Vice President and Chief Medical Officer for the Broward Health System in Fort Lauderdale. Also, Dr. Lenchens is very, very active in organized medicine at multiple levels, being the immediate past president of Florida Medical Association, past president of the Florida Osteopathic Medical Association, and past regent and current fellow of the American College of Physicians, vice chair of the Bureau of Osteopathic Education of the American Osteopathic Association, and former chair of the Public Policy Committee and current senior fellow of the Society of Hospital Medicine. If I were to read all his accolades, I think I would take the hour and a half. So Josh, thank you so much for being here, and the floor is yours.
Of course. Thank you so much. Tanya, if you don't mind, can you bring up the slides? Outstanding. Okay. Well, thank you very much, Dr. Roldan, for having me, and to the Greater Miami Chamber of Commerce for the opportunity to speak to you this morning about this topic. You can go to the next slide. I think that it's most important to try to figure out exactly how we got here. And normally when I give this presentation, I spend a number of minutes on this slide, but I'll just highlight the most important components of this. And when you think about other medications in healthcare, we usually look at a repository of information that comes out in the medical literature to underscore the efficacy and safety of a particular medication. That, in fact, has never happened with respect to opioids. And in the 1980s, there was a number of papers that were published just really to say that people could use these without having any ill effects or any untoward effects. In 96, the American Pain Society trademarks the slogan, "Pain, the fifth vital sign." And for those of you that are in healthcare intimately, you know that paying the fifth vital sign is something that we were beaten up about for quite a while. Coincidentally, however, the same year that was introduced in the American lexicon, Purdue Pharma releases a drug called OxyContin. I'm sure that there was no conflict of interest there whatsoever. 5 years later, the Joint Commission, which accredits hospitals that I've worked at my entire life and thousands of others, promulgated and produced a guide that was sent out to hospitals telling prescribers, physicians, and others that we have inaccurate and exaggerated concerns about addiction, tolerance, and the risk of death from using these medications, and that we should regularly do that. Again, in 2001, that monograph, if you will, that pamphlet was funded by Purdue Pharma. 5 years after that, the federal government weighed in with HCAP scores, which are effectively patient satisfaction scores, and that compounded the problem. And then you fast forward 15 years later, and here we are, 200 plus people die in the United States every day because of opioid-related deaths. Now, when you talk about numbers, it's many of us obviously follow the news, and so billions and trillions don't mean what they did when we were a kid. But to put this in context, 200 people dying of an opioid overdose every day is the equivalent of crashing a jumbo jet into the ground every day, killing everyone on board. If you remember, in 2001, 4 jets hit on September 11th, and the FAA grounded all air traffic in the United States for 4 days. This happens every single day, and yet we still are missing the boat. Next slide. This is an example of where people get their medications from who are not using them for medical purposes. And by and large, you see on the upper right-hand side, that sort of cream color is free from friends or relatives. Nobody means to do others harm. And if you compound that with the light blue and the black wedges of the pie there, you see 2/3 of the country get their medications from their friends or relatives who are really trying to help them out. They're not trying to harm them. Go to the next slide. Unfortunately, what you see here is a line that sort of takes off with the inflection point around 2014. And that line that stands out from the others is a line that represents national overdose deaths. And that line basically is informed by fentanyl. If you watched it on the news or read in the paper, obviously fentanyl is causing havoc in the United States. And you can see this is a slide that's more than 20 years old from the CDC that bears that out. In 2014, when the influx really took off, so did overdose deaths. And in fact, when you speak to the DEA, 4 out of 10 confiscated fentanyl pills are fake. And fake, not just in terms of not having anything in them, but fake to the point that they have, some of them have a lethal dose. We measure fentanyl in micrograms. This is in milligrams. It's 10 times more powerful. Fentanyl in and of itself, we know, is 50 times more powerful than heroin, 100 times more powerful than morphine, which are prescription agents as well. And here I'm talking about the illicit fentanyl. I'm not talking about prescription fentanyl yet. We'll get to prescription in a moment. But I want to craft the talk around the fact that we're not just talking about the guy out of a Hollywood soundstage that you would expect when you think about somebody that's addicted to medication. This isn't just illicit medication. Any controlled substance has the potential for addiction. In fact, in fentanyl, cartels now have gotten pretty savvy. So now they import fentanyl and then they mix it to look like things like Skittles, Sweet Tarts, gummy bears, and sidewalk chalk in an effort to try to addict our younger population. So absolutely something that we need to continue to be aware of. Next slide. When you look at drug overdose mortality, I picked this also from the CDC, and when we compare the state of Florida in 2014, which is the last year or the first year where they started to run continuous figures. In 2014, Florida ranked 33rd in the nation with respect to drug overdose mortality. Now, this is all drug overdoses. You fast forward, the latest data is in 2021, and you can see there's colors on the slide and a legend on the bottom, but basically now we rank 18th in the country. And the lower the number, the worse the state is. Fortunately for us, we're not West Virginia. West Virginia has held the reigning crown of drug overdose mortality for the last decade. So we certainly are not going in the right direction. We have work that still needs to be done. Next slide. Every year, the CDC publishes this data. This shows drug overdose deaths involving, I picked this one, this involves any opioid. So this is prescription and non-prescription opioids or illicit opioids. And what you can see is in 2010, we were at about a 21,000 mark. In 2017, you see that 47,600. So it took only 7 years for us to more than double. Now, in probably 17, 18, 19, those 3 years there, they were effectively pretty flat or plateaued. And then COVID hit. Almost 4 years ago now, COVID hits the United States in March of 2020. We advocated for people, if you remember back then, the spring of 2020, if you were over the age of 65, you effectively had to be stay in your house. If you went out of your house, you were going to get COVID and die. And public health emergency aside, what a lot of epidemiologists were looking at in the fall of 2020 was, what are we doing to that patient population? We take a patient population over the age of 65, highest at risk of despair, loneliness, and grief, and then we tell them that they have to socially isolate. And I had people who were calling me at that time, and they were asking me, hey, is it okay if I make a phone call to my grandmother, or can I walk by the window and can I say hi to her? Of course, that's not what we meant. We meant physical distancing, although now Fauci has sort of backtracked on where that came from. But the fact is, when we relegated those people to staying in their home, look what happened. They resorted to whatever medications they had, and in fact, they overdosed. So you see that the jump up from 2019 to 2020, 2019 was about 50,000, 2020 was almost 69,000. That's a 38% increase in drug overdose deaths. And then in the 20 to 21, it's up another 17%. Next slide. Here now we look a little bit closer. Now I'm looking at Miami-Dade County. All of this data is sourced from federal and state government agencies. This is a slide that looks at all drugs in terms of non-fatal overdose emergency department visits. And those of you that are affiliated with institutions in Miami certainly know this. The federal statistic is over 1,000 people visit an emergency room every single day because of an overdose related complaint. Here in 2022, which is the last data that we have on the right-hand side of the slide, there's if you look at the calendar year, almost 2,200, a little more than 2,200 ED visits that year. That's 6 ER visits every day for overdose related complaints. Now, more than 75% of those were unintentional. So we're not talking about the people that are trying to hurt themselves by and large. We're talking about people that are taking these medications. They don't realize that they're addictive. They don't even realize that they are addicted to them. And then they overdose and they get brought into the emergency room. Of that 2,200 total, a little more than 400 or 19% were related to opioids. So yes, people come into the emergency room because of other overdoses. 20%, 1 out of 5 of those is going to be related to an opioid, and almost 95% of those are all unintentional as well. Next slide. This is the non-fatal overdose hospitalizations. So I told you that 2,200 people came to the emergency room. By and large, the vast majority of those were admitted to the hospital. And of those that were admitted to the hospital, again, about half, maybe a little more than half, were unintentional. Of those that are admitted to the hospital, Again, about 15 to 20% are because of opioids, and by and large, the vast majority are unintentional. 4 out of 5 people unintentional. Next slide. Now, this is from the Department of Health, and this looks at drug overdose deaths for Miami-Dade County. And if you look on the far left of the slide's a little disingenuous because it looks kind of flat. So you say, well, we're not doing that bad. If you look on the far left of the slide, in January of 2020, there were 312 deaths that year, or that month. If you look on the far right-hand side of the slide, the last month that's recorded is June of 2023. What you'll learn about federal and well, many of you know this about federal and state data. It takes a while for that data to be finalized. So we don't have like December of 23 or January of 24. The last data is June of 23 that's listed on this slide, 406 deaths that month. While you think that maybe the slide looks like it's kind of flat, it actually is a 30% increase from the first point on the left-hand side of that slide. Next. In the spring of 2018, House Bill 21 was passed and signed into law by then Governor Scott. And that 205-page law that was enacted on July 1st of 2018 affected 4 main areas with respect to opioids. One was the PDMP, or Prescription Drug Monitoring Program. One, legally defined acute pain, and then put statutory restrictions on the duration of the opioid prescription that we could write. The third affected pain management clinics, and the fourth was a continuing medical education. Those of you that are physicians or NPs, healthcare professionals in the audience certainly know about that, because we have to do that during every licensure cycle. What is the PDMP? It's an incredible repository of dispensing information. So once a prescription is written, it's taken to the pharmacy dispenses it. That information is uploaded into our prescription drug monitoring program. Now we have collaborations. The state of Florida has collaborations with more than 40 states around the nation. So we really have the ability to check no matter where these folks go to get their prescriptions filled. Next slide. But one of the things that is on the PDMP when you sign into it and you're going to prescribe a controlled substance is a risk score, an overdose risk score. And specifically what we're looking at, or what the system is looking at, is it compiles a bunch of information and then spits out a 3-digit score. You see here on the middle top of the screen, 740. That score goes from 000 to 999. Some would argue the higher the score, the greater at risk the person is of having an overdose, whether intentional or unintentional. And on the left-hand side at the top, you see 3 different numbers, and the system breaks down their overdose risk into the different categories of narcotics, sedatives, and stimulants that they may in fact be taking. So in an effort to try to help identify who may be at risk, the system that we have to check now legally by law now provides us with additional information to help identify those that may be at risk of having an overdose. Next slide. Now, when we talk about opioids, I don't want to beat up on opioids 100%. I mean, certainly I don't believe that opioids are the go-to pain medicine for anything in this day and age. And in fact, there's a host of guidelines, if you will, that is published through the federal government that gives us an idea about using opioids appropriately, that we shouldn't be using them in the first line, start low, go slow, when we can increase the dose. Next slide. And then in a treatment of acute pain, we should evaluate the person on a kind of a frequent basis to assess their need for ongoing medication. Next slide. Addiction is certainly possible for all of us. It's a misnomer. It's an urban myth to think that you can't get addicted. As a human being, there's a natural physiology that we have in our bodies. Each one of us has an addiction threshold. All of us are addicts at some point. I'm not making a judgment call. I'm just saying that some may be addicted to alcohol after having one or two drinks. Or in this case, you could be addicted to a pain medication after taking one of them. One pill can get you addicted. Other people can eat them like a sweet tarts and not have any problem at all. But there is a threshold. So it's important to recognize that everyone has an addiction potential for these drugs that are addicting. The drugs have no senses. They have no power to discriminate against somebody based on the color of your skin or your religion or where you came from or what your socioeconomic class is. The pill doesn't have the power to detect that. The pill has inherent addiction potential within it. Obviously, in terms of treatment, there are many opportunities to intervene and treat folks for the addiction, but addiction leads to, it's not just addiction in and of itself as addiction, but addiction leads to a host of concomitant mental health issues such as anxiety, depression, suicide. So it's not just simple enough to provide somebody with an opportunity to take a medicine and get them off of that. There's a whole host of mental health components that have to go into helping folks address addiction. Next slide. In terms of overdose, we're lucky, I guess at this point. I'll show you on the next slide, but mainly these folks that overdose die from respiratory depression, so they stop breathing effectively. And there are some signs and symptoms on this slide to look out for, but effectively, once you identify a possible overdose, the first thing you need to do is call 911. And then there's some other interventions, basic life support interventions that you do until EMS gets there. Of course, if you have naloxone, you can administer the naloxone to the person. There's no adverse effect. There's no downside to giving naloxone to somebody that's not on an opioid, but it will reverse some of the folks that have taken opioids. Next slide. And luckily, the FDA in March of last year, 2023, approved an over-the-counter version of naloxone. I went and bought mine. This is what it looks like. This is the over-the-counter version. In fact, I didn't even have to go to the pharmacy for this. I put the order in online. I used CVS. I went on the website. I ordered naloxone. I picked this up at the front counter. It cost about $40 to $45. This is what it looks like. Here you go. There's 2 doses of that in this box. And one of the things as a background, like Dr. Roldan said, I'm a pharmacist. So the first thing that I always look at whenever I get anything is the expiration date. This expires April of 2026. So this is great. This is $45 for 48 months is not bad. That's less than $1 a month to have this on hand in the event that, God forbid, in the event that somebody should need it. So you can go out and you can get this today. Next slide. In terms of pain and how we move forward from here, it's important to identify the different types of pain. And I don't say this pejoratively or demeaning at all. The fact is, opioids are very powerful analgesics. The simple fact is that they are not useful in every type of pain. Next slide. We need a phased approach to analgesia. And in fact, when you look down on this slide, it's very commonsensical, right? Many of us begin where it says mild. Many of us, if you have pain or you have an ache, we don't go to our medicine cabinet and try to get an opioid prescription. We go to the medicine cabinet, we try to take Tylenol or ibuprofen. That NSAIDs stands for non-steroidal anti-inflammatories, which is effectively ibuprofen, Voltaren, naproxen, those kinds of agents that are out on the market. Any of those are fine to start with. If they don't work, then that's where we engage our healthcare professional and we call for something a little bit stronger. And there are other things that we can do in between the over-the-counter medication and opioids. There's a whole host of medications that we can provide to folks in an effort to try to address their pain. Next slide. But I will tell you that the pharmacological component of it, prescribing medications, is only one part of an effective and comprehensive pain management treatment plan. There's a whole host of other things. I remember vividly when I was a medical student, I was on an OB rotation, and I was working with a doctor that swore that hypnosis was an effective method for people to deliver birth. And I kind of chuckled. Of course, I wasn't disrespectful. I kind of chuckled inside, but I must have asked this lady 35 times after she delivered if she had any pain, because he hypnotized her. She gave birth without any epidural. And then I was just dumbfounded. So look, whatever works for individuals, that's what we should be using. Next slide. There's a whole host of non-opioid alternatives. This goes back to the sort of identifying the kind of pain that people have. The different kinds of pain react to different things. Bone pain is notorious for not reacting very well to nonsteroidals, to the opioids, but reacts very well to nonsteroidals like ibuprofen. What people mistake is they mistake the sedative properties of the opioid for reducing someone's pain. But when you sleep, it doesn't mean that you're not in any pain. Sedation and analgesia, being sedated and then having pain relief, are two completely different aspects. Next slide. There are non-pharmacological interventions as well that we should and could employ instead of or in addition to medication. So many of you look at hot and cold, right? If you sprain a muscle, you could take an ibuprofen, provided that you're allowed because of your medical conditions and whatnot. But you could take an ibuprofen and then put a heating pad on it. So we use these things every day. There's nothing to say that we shouldn't continue to do that. Next slide. In terms of how we address what we did at the very beginning, prevention begins at the home. Each of us in and of them ourselves may have medications that could be addicting to someone else. And if you check your medicine cabinet and you have that and you're not using it, it's been a long time, you don't need a rainy day fund. Your doctor will prescribe you something when it's needed. You should get rid of it so that you don't fall into the bucket of 2/3 of the population where it's free to friends and family, it's stolen, or it's bought from our friends and family. Next slide. In fact, the FDA came up with a flush list. So there's actually a list of medications that we are encouraged to flush down the toilet. Many controlled substances fall into this category. That's the third bullet. Working our way up, there are also DEA authorized collection locations. If you click on that link or go to that link, you can type in a zip code, any zip code in the nation, and like on trying to find a gas station, those things will pop up. You can bring your medications there. Certainly some of the pharmacies have those cases that I showed you, those sort of book depository things that you can put them in. And then finally, every April and October, on the last Saturday of the month from 10 in the morning till 2 in the afternoon, there's a National Prescription Drug Take Back Day. Next slide. I want to end with just two more slides here. One is I found this. This is a slide that I pulled from last year. In fact, Project Opioid is a coalition that brings together business, faith, government, and philanthropic leaders to create a major impact on the overdose crisis in their communities. It's backed by Florida Blue. Last year, they partnered with the Miami-Dade Beacon Council in an effort to have an awareness day. I think that this is not, thankfully, this is not unique to Miami-Dade County. During my year as president of the State Medical Society, I bounced all over the state, and different counties, thankfully, are doing things very, very similar to this. But I commend you guys, the Beacon Council, Project Opioid representatives, for taking the initiative to do this. Next slide. Finally, the bottom line is that pain management really involves an individualized and multimodal approach that's built on the foundation of educating the patient and capped off with realistic expectations, so people know what they're getting involved with. With that, next slide. This is my personal email and cell number. You can take that down. I'm happy to answer any questions at any time. I know that your agenda is very packed. If Dr. Rodan thinks that we have some time for questions now, I'm happy to answer whatever I can right now. Thank you very much for inviting me this morning.
Absolutely. Thank you so much, Dr. Lynch. It's great information. And obviously, I think that we all have to be aware because, yes, a lot of these opioid addictions start at the home in the sense that we really don't know what we have in our cabinets until we see that the problem is upon us. And that goes to the next thing of addiction. You know, no one is born knowing they're addicted, right? We just need to have that first touch of it to then know that the individual is in trouble. So I want to go ahead and open it up. I think that this is a problem that's across all age groups. Of course, we do know that we have very impactful and societal problems with our teens, with our youth, but also it extends all the way to the elderly, especially the elderly, that they are treated for their pain. And yes, I agree with you. I think what you just said of the rainy day fund, the elderly population, they love that because they fear that they're not going to have the medication readily available. But to your point, you know, please throw them out. Don't keep them because you don't know if that grandchild's going to open up the medicine cabinet. So again, I would like to open it up. Anyone have any questions for Dr. Lynch's this morning?
I have a quick question, if you don't mind.
Sure, Charles, go ahead.
Hey, Dr. Richards, how are you doing?
Nice to see you, Charles.
Same here. I'm going to ask you a tough one, so be ready now. With the opioid crisis, everyone knows is very, very serious in the country. But what's going on also coming up for pain is obviously the medical marijuana issue. And in the state right now, in fact, on my iPad, I'm listening to the Florida channel on some hearings in the health committee, talking about the hemp bills that got out of control and trying to control that, and recreational, trying to put the caps on recreational as it comes about. Do you see that also maybe a different category as opioids, not as maybe serious as opioids? I know one of the things that they're trying to do through the state now is saying that not to be able to use medical marijuana, not marijuana you buy off the streets, in treatment centers to help people get off of opioids addictions. And the state has come out and said, no, you just can't do that. So, I mean, just your thoughts, you know, not right or wrong, but just your thoughts.
Yeah, it's a great question. There's a number of aspects of cannabis that are sort of in the limelight right now. Not just here in Florida, of course, where the recreational component is undergoing its heyday, but even at the federal level, where there's been a petition to the DEA to reclassify cannabis, which is presently a Schedule 1, which means you cannot prescribe it. Nobody's writing a prescription, taking it to CVS or Walgreens. But there are people that obviously from several years ago, from the amendment that passed, that can use it for medical conditions.
Right.
I am familiar with some of the published literature that has looked at trying to move people off of opioids using cannabis, most notably in the VA system for post-traumatic stress disorder. I've read papers on that. I think more to come. I've also started to see, and the reason why I say that is because I've also started to see papers that come out with what happens to your brain after long-term use and how long are you really impaired when you're driving a motor vehicle. So there's additional information that I think is coming out. I have no doubt that's why at the federal level, there's a petition again to reschedule it from Schedule 1 to Schedule 3. As you may know right now, since the 1970s, when you weren't allowed to do anything with cannabis in terms of research, the University of Mississippi is the only federally designated cannabis location for research. Moving it from Schedule 1 to Schedule 3 obviously opens up a lot of opportunity, not just for people to be prescribed it legitimately, but also for people to do the much needed research on it that I think is necessary. Unfortunately, at present, the only data that we have is data that comes out of other states that have liberalized the use of it and looking to see what happens to those folks. and looking and seeing what happens to some of the folks that have been on the registry here that we've had in Florida for the last several years. So I think more to come. I don't know that I'm for or against it yet. I think that there's data kind of on both sides, and I'm interested to see where it comes.
Great. Thank you very much. I appreciate the comments.
You got it, Charles.
Thank you, Charles. Anyone else? Anyone else have any questions for Dr. Lynches this morning?
Yes. Hi, good morning. My
Good
name
morning,
is
Dr. Banshi.
Good morning. I used to be scientific director at NIDA, so I witnessed Nora Volkov, my boss, for a decade almost, fighting this relentless fight. But speaking locally, I loved your presentation. You were very concise and to the point. Do you think we have an opportunity locally, or if you could elaborate on ideas or possible solutions to do something that in this ideal world, I mean, right? It's easy to talk, but could be considered as an example on what could be a solution or ideas to this problem, as opposed to big picture, I get federal, they have laws, etc. But locally, do you think that there would be ideas that we should think about to set an example on what could be done?
Yeah, listen, I think that's a great question. I think that this project opioid that I only really came to understand recently, I think it is wonderful, tying in, and maybe this is an opportunity for the chamber to tie in different facets, if you will, of folks that are working. NAMI, as in Miami-Dade, is a wonderful organization for mental health. You know, is there an opportunity for them to play a role in supporting the mental health, for Project Opioid to continue to do what it's doing in leveraging the resources and the communities that it affects, the chamber, the Beacon Council, and then also there in terms of addiction, it's not just a facility, it's not just going into a rehab facility, but it's also the prescribing of medication. And the federal government, I'll hone in a minute, but the federal government did do something that was very good. At the end of 22, they passed a consolidated appropriations, which is basically a train that goes through the federal government where they spend trillions of dollars. I'm not going to comment on that part, but two aspects of that, or one aspect of that, was in that huge train was relieving us of the necessity to obtain an X waiver to prescribe buprenorphine. Buprenorphine is a class 3, a schedule 3 controlled substance, FDA approved for the treatment of opioid use disorder. And there were a lot of obstacles to folks being able to prescribe that. They had to go through an 8-hour training course. They had to petition the DEA to get a separate DEA certificate. All of that stuff is gone with the passage of this bill. So anyone who can legally prescribe a controlled substance can now prescribe buprenorphine. And before there were patient limits, you could only have so many patients per year, as you know. Now those limits are gone. So what I think is that there's an opportunity not just to leverage sort of the different groups that are already trying to bite off little pieces of it, but also to engage practitioners like NPs, PAs, physicians in an effort to try to educate them just on buprenorphine. Listen, you don't have to be a pain management clinic and see, you know, all these patients. Don't worry, you don't have to do that. All you're doing is engaging the patients in facilitating their care by helping them address a problem like opioid use disorder, no different than you would address hypertension or dyslipidemia.
So this is I apologize, kind of an ignorant question, but do you have a GMCC structured education program that could go through all the major local hospitals and clinics so that we start from the grassroots, in a sense, to educate people on exactly what you were saying, that we kind of set a basic gold standard of information locally? I mean, is there anything like that?
Yeah, that's a good question. I don't have a repository of that. I think that certainly members of the chamber who are in healthcare could query their own local organization to see what they're doing in effect to address the issue, and then perhaps feed that back up to the chamber in an effort to have them compile that list and then really be the connector, which is exactly what you guys do, right? I mean, to be the connector so that you can facilitate that what one person's doing here, one person's doing here, one person's doing here, that can really blossom into something that we can address on a much more regional level. It's a great idea.
Anto, I think that's a great idea, just as a matter of introductions. And I know I have Susan and Peter with their hands up, but Dr. Bonci is involved with GIA Healthcare, and there's going to be a symposium. He's going to talk about it a little later, introduce it on mental health. So more to come on that. And I agree with you, Josh, that, you know, this is our priority, right? To bring in community leaders together for a common cause. And just on the chat, we have Dia that just said that today's New York Times, you know, there was an article on construction industry and drug overdose. So, I mean, it's everywhere, right?
Yeah.
I mean, no one is exempt from a potential drug, mental health, number one, and then obviously
Sure.
drug overdose. And we hope that they can make it, right? Because we
Yeah.
know that they could also pass away with that. So let me just take Susan. Susan, you had your hand up. Can you hear us? I think Susan froze. Okay, so matter of time, okay, let me just go on to Peter.
Can you hear me?
Oh, Susan, you're there? Okay, yes, we can hear you. Can you hear us?
Jason,
Okay, Susan, can you hear us?
I can hear you. Can you hear me?
Yes. Go right ahead and
Can you
ask
hear
your
me?
question. Yes,
Okay.
ask your question, yes. Okay, so Susan,
CEO of Nonprofit.
okay,
You can't hear me?
yeah, but you're breaking up. Let me tell you, because of I'm looking at the time, hold your question. Let me go on to Peter and I'll come back to you. Is that okay? Yeah, because she's going in and out.
Yeah.
Okay, Peter.
Good morning, everyone. Thanks, Doc, for a wonderful presentation. Very informative. How does Miami-Dade stack up against the other counties in the state as it relates to this issue?
Yeah, that's a great question. Without giving you a set number, Miami-Dade, as you would expect with other urban counties, is in the top 25% in terms of overdoses in the state.
Okay, that's helpful. Thank you.
Yes, sir.
Okay, let me try again. Susan, are you there? I really would. Susan? I don't see her. Okay, well, I guess we'll just circle back with you, Josh.
Sure.
On the question, I'm so sorry that she has a bad connection. So anyone else before we close up and give a big thank you? Oh, Susan, is she back? Okay. Anyone else before we close up and give a big thank you to my colleague and great friend, Dr. Josh Lynches, for today's presentation. Dr. Lynches, is the possibility of sharing your slides with today's participant? Okay.
Of course.
By the way, this is being recorded, so also those of you that would like for someone else who was not able to be with us this morning, this is a recorded session, so that's also available. Okay, well, thank you again. Thank you so much. I know you're very, very busy.
My pleasure.
Always love to pick your brains on such an important, like I said, not only in healthcare, but societal challenges. So thank you again and have a great day. We're going to transition. You're welcome to stay, Josh. We're going to transition to our meeting. Okay, Tanya, can we have the agenda?